Fine. So, you got it. Right. Hi to everyone. I'm Neha. I am an ST2 in ACCS ED at the moment, and I'm currently in my ITU block. I'll tell you how it goes so you get an idea of what that means. Anyway, so I don't know how well you can see that, but that is a generic sort of flow chart of how things should progress from sort of your qualification to F1, F2, and then what happens. In brief, it's like any training program in the UK. Obviously, you do your foundation training year 1 and year 2, by which relatively most people should have a brief idea about what they're going to do. But obviously that's not happening these days. I didn't. I had a completely different career in mind before actually ending up where I am now. I wanted to do general surgery all through medical school and all through foundation years. So I actually had I had 4 surgical jobs. I had 1 GP placement and 1 medical job, and that was it. I hadn't done an ED job at all. So I had no experience of it. Before even but then obviously I realized surgical training was ridiculously long. They needed a lot of added things. So I although I did have a lot of sort of presentations and publications, it just felt like I just didn't want to do it for the rest of my life. It just would have been quite tedious to do it at different points in life. Some people can manage, but I thought it'd be difficult. So anyway, so I locumed after F2. Took time. So the F3 year has now pretty much become official because it's on all documentation. People actually sign off things saying F3. And I'm like, okay, it's an actual designated year now, pretty much in most trusts. So I did that, and during that year, I did a lot of other things. I did trauma, orthopedics, etc. But then ended up doing ED. Has positions available, so you're very likely to get ED locum positions, and that's what I did. So I took up ED then, turned up at my first shift, which was a night shift actually. That was brilliant, wasn't it? I should have actually thought better, but anyway. So turned up on a night shift in ED without knowing anything, literally nothing. All I knew was how to do some bloods and probably put some, but not really in a sort of emergency setting. Anyway, so anyway, very daunting, but very, very supportive senior. Somehow I managed to get through that first night, and I thought, whoa, I haven't actually slowed down. That was such an adrenaline rush. I just continued for the next few months without really giving it much thought. I was obviously probably even worse than F2 at an ED level, just because I had no idea. And I literally was like, okay, I'm not a trainee, but I'm just here and I don't know anything. So it's pretty much at that level. Anyway, I think at that point, I decided this is quite adrenaline fueling. This is very, very exciting. So if not surgery, maybe this is a good idea. And I basically stuck to it then. I only locumed in ED then, didn't take up any other jobs. And eventually when it came to training applications, I thought I may as well do something that I've found some footing in rather than starting right from the beginning somewhere else. And that's where I then applied to ACCS anyway. But before that, I was already working at a middle grade level before I actually applied for training, solely because I don't know how many of you are an F2 or F1 or whatever, and how many of you have ED jobs coming up. But once you start A&E, you actually pick up a lot of things. And I say this to all medical students, all my colleagues. Even if you don't want to do emergency medicine in the future, even if you want to be a GP, you need everybody. I think really, honestly, I would strongly advise needs to do an A&E job, even if it's only for a month of locuming, a week. Not in an active clinician type of role. Even if you're just a medical student who's just watching, you've got to have some exposure to A&E, simply because I think it shapes doctors in such an amazing way. You become a well-rounded and a more wholesome doctor. And yes, it's busy, yes, it's crazy, but you learn a lot. So just do it. Even if it's shadowing somebody for a week, just do it. Or even if it's in a busy day, you want to go for a week, you want to go for an evening or whatever, just go sit in recess, maybe just nicely ask the middle grade if they'll let you just watch them. But do it, because you'll find it invaluable. You'll pick up things that without even realizing you're picking things up. And that is why primarily I want to do ED. Anyway, so this breaks it down for you. So what actually happens? So if you do want a career or do consider career in ED, there's normally a sort of generic pathway for all UK graduates, and that is the ACCS, which stands for Acute Care Common STEM. Now, Acute Care Common STEM normally encompasses 3 ED, anesthetics, and acute medicine. Depending on sort of what you apply for and things, then obviously your routes may eventually change, but you do branch out. You do need to start off with ACCS and then branch out immediately after sort of your core years, as it were. Just like CST or CMT or core surgical training or core medical training, ACCS is technically for all the acute specialties. There's 2 other routes called DREAM or CSER. So DREAM is basically direct route of entry into EM. That's normally for the overseas graduates who would have sort of done a certain level of, so they would have basically worked in ED or done a sort of, wherever in their parent countries or somewhere abroad, maybe have a reasonable number of years of experience somehow. So working already at a pretty much middle grade level in wherever they've come from. So they can opt for DREAM. And usually it depends on how many exams they've done, how many years they have under their belt, where they've joined here. So which trust has actually employed them as a sort of training, non-training grade, staff grade doctor or whatever. So you can then decide on whether, there'll usually be a supervisor who oversee all this and they'd advise them to go on to DREAM. Or there's something known as CSER or CSER CP. Now, CSER CP stands for Combined Program, and that's what I think the RChem or the Royal College of Emergency Medicine now is promoting. So that's a similar thing where you could get into ED training by literally coming over from somewhere abroad, and you've got a little bit of practice, or you've done some things abroad, you've done some exams, but you're not actually a qualified sort of ED physician. So alternatives, a large majority of UK graduates, it would tend to be the ACCS. So what happens? So ACCS, like I said, stands for Acute Care Common STEM. There are 2 further deviations within ACCS. So there's the run-through training, and then there's the core training. So what that means is once you get offered a place for ACCS, they then send you an email asking you whether you want to be a run-through trainee. So you can just start at ST1 and you finish at ST6 and you've CCT'd, and that's it. There's no re-application, there's no re-interviews, nothing in between. Pending, obviously your ARCPs and stuff, you're graduating at a good level. Training, on the other hand, is CT1, 2, 3, and then you stop at 3, and then you reapply at ST4 level. The advantages and disadvantages are obviously several. I am a run-through trainee. I didn't opt for core training just because I didn't want the hassle of reapplying and interviewing when I already knew what I want to do. But a lot of my colleagues are usually not that certain, solely because A&E is a very, very busy, very, very challenging specialty to actually, it's very easy to get into, but the difficulty is actually sustaining it and finishing it up until CCT. So a lot of people actually opt for core training, and the benefit with that is it gives you the option of reapplying into either anesthetics or acute medicine, the other 2 stems of ACCS, because you've already would have covered the sort of core years within your CT1, 2, 3. So you could easily show a little bit more dedication, maybe show some audit, some research, and opt for core training. So the only difference with those 2 is core training gives you a bit more flexibility. You basically reapply and you can switch from ED to something else. Whereas the run through is you're stuck with it. You finish the 6 years, whatever, and you're done. So what happens? Either way, whichever one of those you select, you still need to get through the first 3 years either as ST123 or either as CT123. So the first year normally is 6 months of A&E and 6 months of acute medicine, followed by the second year, which is 6 months of intensive care, 6 months of anesthetics. And then you have the third year where you do pediatric emergency medicine for 6 months and you do trauma for 6 months. Now, although they say trauma and they try to put you into a major trauma center in your ST3 or CT3 year, you are placed at a trauma center, so you're more likely to get trauma experience, but you're primarily based within a normal ED, so you basically see everything, but it's trauma focused. So those are your first 3 years, and then you go on to higher specialty training from ST4, 5 into ST4, 5, and 6. So what actually happens? So you apply via Oriel, which is, I think, the same for most specialties anyway. You apply through Oriel for all specialties now. And then you give what we call the multi-specialty recruitment assessment, or the MSRA. Now, MSRA wasn't in place when I applied. We only had application, and then we had court interview, and then that was it. But MSRA is something they've started from last year. So all ED trainees now, just like GP, ophthalmology. So I think there's a handful of specialties which use the MSRA, primarily GP, radiology, ENT. I think ophthalmology, I'm not sure, dermatology, one of those, a few of those. Anyway, then you get your interview offer. Then you get an interview offer. Along with your application score, MSRA score, and your interview score, you may or may not get an offer, and then you start in August. Now, offers generally, the interviews normally are held between February to March, February, March, April-ish. Mine was, I think, beginning of March. And then you get an offer at a place between sort of end of April towards May-ish. And they give you a fair 2-3 weeks to sort of accept it or whatever. Once you've accepted it, then they send you an email asking, do you want to be a run-through trainee or a core trainee? And then you start in August. They do ask you to rank your deaneries and stuff once they've offered you a place where you want to be. They can, often within the deanery, they even ask you to rate sort of which hospitals you would like. So I think thus far, I've not heard of anybody who's not been given the hospital they want. So most people actually get what they want in the first sort of 2 years. You're normally kept in the same hospital for the first 2 years. It's the ST3 year or the CT3 year that you'll be moved to a trauma center. Anyway, so this is the boring bit. So what do you need to do actually to get to this stage? Obviously, you need to be a doctor. You need to have your foundation training done. You need to have evidence of specialty exposure. So if you actually go to the person specification under ACCS ED, they mention several, they actually mention bits and pieces, obviously, like any application, leadership skills, and you're a good communicator, and you're a good team worker. And sorry, that's my dog that literally is barking out the door. So let me just let him in before he creates a ruckus. Anyway, so yes, so it's got all those the usual person specifications, but also you need to show them why you want to be an A&E doctor. Just like any other specialty, if you've not done it, you can't just apply to it and expect to sort of get in. It's pretty obvious, isn't it? So you basically got to show them some sort of specialty exposure. So have you done a week perhaps as a medical student? Did you have an ED placement? So when I did ED, we had a couple of fourth-year medical students, fifth-year medical students who'd just come. They sort of lumber about in the evenings. I think a couple of them even did like half a night shift or whatever. Even that would count as long as you present it in a nice way and say that, yes, that's made a difference to you, that sort of helped you make a decision to do this. But you've got to show some sort of evidence. So you've done it as a medical student, or you've had an F1, F2 job. I think F1s normally don't actually get ED placements, but F2s do. So whether you've had a job and you've had 4 months of it, what's happened in that time. So you've got to show something. Or have you locumed in your F3 year and you decided to just do ED then? Or a personal experience, some sort of specialty exposure, so you know what it is. Teaching, research, audits, these things look nice. I didn't have any audits in ED when I applied, but I know that they prefer it. You get extra brownie points for that. So as best as you can, even if you could do something quick in your local hospital, any sort of audit, it could be the most mundane thing. It could be sort of the numbers or how many attendances on a weekend with, I don't know, trivial things, or how many fractures in children over a summer, or something like that. So even minor things, if you've been involved with, just, all you need to do is ask a senior, somebody is the audit lead in that department, and they'd happily take you in, especially if you're going to do the data management and whatnot. Anyway, now the references bit I've actually put in bold because they do need references from whatever job, the most recent job you've had. It can be a locum post, it can be anything, but I've highlighted it because the person specification actually says they do contact your referees to ask them about how you are as a person. So most of those tick box things like leadership or good communicator or a good team worker or manages time appropriately, is clinically safe, is very sort of conscientious and things. So those sort of general points are taken off mostly by references. So it does say application / references. So they contact your referees to sort of gather information about that. So think a bit about who you would put on it. Obviously, it's ideal to put people who've been mentoring you through the locum phase, or it could be anyone in your F2 year. It doesn't necessarily have to be an ED clinician. It could be another supervisor, perhaps a clinical supervisor or an educational supervisor who's been very supportive of you. Even they can give a generic reference for you. It doesn't have to be an ED clinician. So keep that in mind. The MSRA, so although I didn't give it, I have a lot of friends who've given it, people who've gotten to other specialties and stuff. Anyway, it's usually comprises of two different types of sections within it. So the first section is a professional dilemma section, and it's just like an SJT that you would give to sort of the SJTs that you have to get into foundation training. So it's similar to that. And then the second one is a clinical problem solving one. The clinical problem solving one obviously is aimed at a junior level. So it's not technically, you don't need to know a whole lot of physiology or a whole lot of anatomy or biochemistry for it. It's not like prepping for a proper clinical exam. But I think out of the two, the trickier part is the SJT bit, because it gives you sort of everyday scenarios. And like the SJT, no answer is, I mean, a few answers may be sort of outrightly wrong, but usually 2 or 3 are the ones that you would probably think about a bit more, because different people do things differently. So that's something, I mean, I think these days there's a lot of examples online about what, it's a generic exam about what it'd be like. So I think throughout sort of all specialties, the questions remain the same. It doesn't matter what you're applying to. So it's not focused towards ED. So you don't necessarily get only ED questions. You don't, it's not tailored to what you're applying for. It's just generic. It just tests broader sort of junior level knowledge. So it doesn't need a massive amount of prepping, but obviously just be aware of what it is. You may need to do some revision, go through sort of past questions and stuff. And I mean, briefly, I've looked this week, and there are a fair few question banks that give you sort of examples of what could come up and things. This is a brief example of sort of a dilemma question, the SJT question. So obviously it's telling you you're an F2 doctor. You're asked about a mother with a 4-month-old baby, reports coughing, sneezing, he's developed a temp this morning. Mother tells you there's no rash, seems well, blah, blah, blah. She tells you it was mainly for advice. So obviously it's over a phone. And now they ask you to rank the responses to the situation. So what you would do first, what you would do sort of last. Obviously, prescribe the child some amoxicillin it's pretty blatant. You're not going to do that before talking to her, before doing other things. You're not, that won't be your first thing. You may do it, but it's not your first reaction. It's not going to be that. So in order for this to sort of happen, you may need some practice. So SJTs normally require practice in terms of not knowledge per se, but what are they looking for? Are they looking, so ideally what they're looking for is a safe clinician. somebody who thinks rationally, who's got a logical way of sort of putting things in order and saying, okay, this is what I'm going to do first, this is what I'm going to do second. So that's ideally what happens. And I'm assuming most of you, if you're sort of F1s, F2s, would have done SJT anyway. So you would have a rough idea about how it goes. Right. The interview. Obviously, because of COVID, just like several things in the world, it's currently virtual. I had in-person interview in London. I had scenarios. So we were given scenarios, 10-minute scenarios each, and we sort of rotated through them in circuits. Where there were two consultants sort of sat there, and they would give you sort of prep time. You go in, you do this station, you come out. It could be anything. So we had a mix of ethical, we had a mix of sort of planning, presentation. One was solely clinical, one was based on our portfolio, and they'd ask us questions. So right now, it is, as I said, virtual. And I think going by what they've said online is there's a panel of consultants, usually about two each, who asks you questions based on, it could be, again, a clinical scenario, and then your portfolio, and an ethical scenario. So these are the sort of broad aspects that they would question you about. Obviously prepare for general interview stuff, but the most important thing, and I think even now going by sort of what I've read, is the portfolio. So they asked me, so you give them your portfolio, you literally hand them a paper hard copy of your portfolio of all the things you've done so far. That includes your degrees, your courses, things you might have done at medical school, things you've done as an F1, F2, everything, literally your entire career, a hard copy of your entire career thus far, and you hand it to them. So the portfolio, I found that very difficult at the time because I hadn't really built up my portfolio as much as I thought some of the others had. Some of the others actually literally had a big wad of like files and couldn't carry it in. I literally panicked because I saw that and I went, oops, I don't have these things. But it doesn't matter. It's not a quantitative thing, it's a qualitative thing. So it could have been, so I did still include all my surgical papers and all that in there, because although it wasn't relevant to ED, it was something I'd done. So no matter what it is, just make sure it's in there and it's in one place and it's accessible and you can give it. So I know a lot of things these days are all sort of online, and you've probably got everything on USBs and stuff, or your hard drives, but make sure you still have a paper copy. Not just, I agree, these interviews are virtual, but even generally in life, I think everybody's always advised me, all supervisors, all consultants, you need to have a hard copy of things just as a backup. So make sure you have that somewhere. Anyway, so yes, organize things. So even if it's online, obviously tab them and make sure it's in a sort of order. So medical school, or even pre-medical school, there are people who've actually done stuff pre-medical school. So I actually worked in a special needs sort of care home before I went to medical school. So I included stuff from then all through medical school, whatever you did, societies you're part of, if you led something, if you organized something, all that, your exams, your special grades, if you excelled in something, if you got an honors in something, merits, things like that, sport, through medical school, all that, coming to your degrees, and then your foundation years. What did you do in your foundation? What were your jobs? Did you get a recommendation letter? Did you get something great out of a patient? Everything. So everything, but just make sure it's in order and it flows in a nice way, including obviously audits, research, everything else, papers, publications. It could be menial. It could be something that you've thought isn't an amazing thing, but just put it in there, because it often shows how broad a person thinks. I still remember one of the consultants in the portfolio station actually asked me, what do I do in my free time, and how important did I think that was? I know they ask this in most specialty interviews, but in ED, it's more important than normal. And solely because if you've had an ED job, or if you've had any exposure to A&E, you will know the hours are totally erratic. So we don't always work social hours, as it were. More than often, you'll be working evenings, late, twilights, nights. You could be on a twilight one week, you could be on nights the next week, and you'll be expected to be 8 to 4 the week after. So literally it's very erratic hours. The stress levels are very, very high. And it's pretty evident when you walk into an ED. Most doctors are really, really stressed. It could be anything, but it's primarily the work and the pressures of where you are and what you're doing. So it's very, very important you show them that you are somebody who can offload, or you have a stress reliever, you've got a hobby. And they will specifically ask you about hobbies. So they actually asked me what my hobbies were, how often I played whatever badminton, or how often I went swimming, how often I read a book or even watched a film. So they can get quite sort of finicky about that. So just bear that in mind. So I would hope by this stage you're all well-rounded individuals anyway, because you're in medicine. But regardless of that, I think if you're choosing a career in A&E, that's very, very important. So make sure you mention that, make sure you're prepared for it. And if you've done something outstanding, even outside of work, then that's something to be proud of. So that's an achievement. So it'd be good if you could show that. Have you run a marathon? Have you raised money for something? Do you do charity things? Like whatever it is, things that excite you, just put it in there. So make sure your portfolio is organized, because I mean, you'll see it's not just getting into specialty training of anything that the portfolio is important for. The portfolio actually runs through your entire career, even after you've CCT'd and actually become a consultant. It's very, very important you maintain a portfolio throughout your retirement, pretty much. So you've got to do it. I actually maintained a portfolio until I locumed, and then I left it. And then I applied for specialty training and then realized, oops, I don't have enough things. Whatever, I somehow got in. And then the sort of all of my SD1 year, I didn't maintain a sort of separate portfolio. So we obviously have the specialty training portfolios online. So we go through that. We do that, but I didn't have another sort of patient database, as it were, of anything. So I've been told off by my educational supervisor 2 months ago now, saying I really, really need to get on it. So he did mention it to me last year at the beginning of SD1, but I really didn't pay much attention to it. And I think most trainees at that point kind of think, do I really need it? Probably not. But it's very, very important. He's shown me why. So you really need to maintain it. So so the other portfolio that he's told me off about is actually just a generic one, and he just wants me to put in anything interesting. So an interesting patient, something interesting I've learned out of that. Even if I haven't directly been involved in that patient's care, what have I learned out of it? Have I done a procedure, something different? Was something difficult? Was it a patient communication thing? Was it breaking bad news? So now I maintain an online one on my phone, so I can just do it as I'm at work and I don't forget. So I've started doing it, but it is important. You've got to do a portfolio. It doesn't have to be the NHSE portfolios that you've maintained for F1, F2 year, or it doesn't have to be the specialty training portfolio. You need to have a separate, your own portfolio that everything goes under. It could be the most mundane thing, but it needs to go on there. It's just a record of how much you've done and why you've done it. Anyway, what app is that for portfolio online? So, what do you mean? The one that the one that I use?
Yeah.
So the one I use is actually called, let me tell you, it's called Logbook. EasyLog, actually. It's called EasyLog Logbook. It's the one that the anesthetists normally use. So all my anesthetic friends use it. They advised it to me because there's several on the App Store, but EasyLog was, I think, out because I downloaded a fair few, went through them, and I found some of them really complicated. EasyLog was probably the best I found. So I now log everything onto EasyLog, everything. So if you actually have a look at my EasyLog, there's random things on there. So I literally have patients that I've presented on during the ward round, patients that the consultant was, querying about breaking bad news to the patient, to their family, but I was just sort of there and I listened to it and I thought, oh, how is she going to do this? So it's things that make me think even at work. So these are everyday things that we don't think of logging these things. Which is why it's important to have this sort of accessible. I think I primarily didn't have a logbook all of my SD1 year because I'd forget to go home or whatever in my free off day, sit down, and who wants to actually make an Excel sheet and da. It just felt long, which is why I didn't do it. Whereas now I've got it on my phone, it's just easier. So even if you're a medical student, even if you're an F1, F2, whatever, just do it. It just shows evidence that you've done something that doesn't necessarily need to go formally on paper, but you have it, and you can just quickly be like, oh, actually, I've been maintaining this on my phone. And it includes this. And it just looks so much nicer. Anyway, so you need a formal portfolio, which is fine, but you also need to keep a logbook of everything, just your entire career. Anyway, so the rotations, so I've briefly explained to you, obviously, we go through 3 years, six months of each thing. Obviously, you have clinical work, which takes up almost 95% of your time. The other 5%, obviously, you do need to have, well, the aim, I think the RChem website advises you to aim for an audit a year. So you should aim for one audit cycle. So you need to have started an audit, made a presentation, presented it either departmentally, nationally, whatever, somehow, and then close the loop. So it's important that you close the loop of the audit. So a lot of people usually present it departmentally, and then that also is a good thing. Yes, you've got it, but it's ideal if you can close the loop. So you've implemented something, your audits found something, and you've put, I don't know, changed guidelines, or you've put in an extra form during discharge, or something that facilitates easier work, or sort of methodical work, what it's done. And then you need to close the loop by literally saying, re-auditing it and saying, okay, look, now we've improved the numbers. We've made a difference. My audits made a difference. So it's better if you can close the loop. It's not sort of mandatory, but it's ideal if you can. Obviously procedures. So procedures also can go in your logbook. So it also goes on your e-portfolio, obviously online, but it can go, all procedures can go on your logbook too, even if it's sort of menial. So often people think, oh, on my portfolio online, I've put a femoral stab. Do I really need to I don't need to send off 2-3 other fem stabs I've done. It's not important. But although you don't need to put it on your formally portfolio, you can put it in your logbook, and you can say, oh, I did 5 fem stabs on that weekend. Actually, I did 10 in 4 months or whatever. So make sure you have that. Conferences, any sort of conference will do generally. The RChem conference happens in March. So this year there's one at the end of March, I think 29 to 31st in Bournemouth. I think over the last 2 years, they've been sort of, because of COVID, a lot of things have gone all over the place. This year, they're holding a proper conference again. But it doesn't have to be the ED-centered conference. It could be anything, anything that interests you. RCP conferences, you can go to things, trauma conferences, pediatric medicine, pediatric emergency conferences, things like that. See what you can find. Most of them, most deaneries will be happy to reimburse. So they reimburse us for most conferences that we can show some sort of link towards. So I think all we need to do is show a link towards ED of why it would impact my clinical training or blah, 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 and they'd be happy to sort of sign us off for it. Courses. Obviously, courses are very important. Every 6 months, you get a little ping from either your clinical supervisor or your educational supervisor asking you what you've done, which course you've signed off to, and what's happened. So you do need to do them. So there's a load of approved courses that the deanery sends an email out every 6 months to us about. So they've actually just sent ours last month. Anyway, so it includes all the ACCS streams. So the email I actually have has ACCS anesthetics, ACCS acute med, ACCS ED, and these are the courses that they would approve us for. It includes a lot of things, starting from simulation, clinical skill stations, ATLS, ALS. ALS is obviously mandatory, but you make sure you're sort of valid for 4 years. ATLS you need to have as an ED physician. You need to have ATLS. That's an absolute must. You need to start off either at ST1 or 2, but you definitely need it before ST3 before you go onto your trauma block. APLS stands for Pediatric Life Support, Advanced Pediatric Life Support. So you need to have these things. So these are mandatory. They're valid for 4 years, but you can recert after that. Leadership courses. So I think in the last sort of 2-3 years, they've started tailoring training to basically try and get us into more leadership routes, because often leadership stuff is left to the higher trainees or post ST4-5. But I think what they've now realized is it's better for trainees to grasp this earlier on, sort of ST1 onwards even. So even if you can get onto sort of basic leadership courses and stuff, and there's a load of them. You can literally type in leadership courses in the NHS and you'll get like hundreds of them come up. So you can pick up any random one through the year, and they'll happily sort of encourage you to go on those. So it just preps you for high specialty training. That's what it's primarily for, but it's not absolutely must at this stage, at the sort of ST1 to 3 year. And then exam prep courses. So they don't reimburse you for the exams themselves, but they do for any prep courses you may go for, say primary, intermediate, or your last part. So all those prep courses are part of that. Also under the clinical skills. So clinical skills is a relatively new thing. So the ACCS requirements for sort of DOPS or procedures every year include several things. So we have chest drains, we have open and selling a chest drain. So the last time I saw an open chest drain was never. So I've never seen an open chest drain in my life. That's never happened unless it was a traumatic sort of out of hospital thing. In ED, we never do open chest drains anymore. So most chest drains, or 99% of them, are Seldinger techniques now. So if I wanted an open chest drain signed off, the clinical skills station would be the best. So that's where they would teach you open chest drains or as a sim sort of thing. The other thing would be cardioversion. So if you're finding it hard to sort of go on to, the cardiology thing, or you haven't seen somebody getting shocked in your ED, you could go on to the clinical skills and they could sign you off for those things on your portfolio. So all trainees in ST1 2 year would look for clinical skills sort of days to become available. And the deanery lets you know, oh, there's a clinical skills day coming up in Warwick or Coventry or QE, and you just sign up for those. So exams, like any specialty, there's Royal College exams. So the RChem exams that you need to pass and have under your belt. So previously it was the FChem, which was very complicated. And I think that in itself put a lot of people off A&E training. So a lot of people actually never got in. So the FChem used to be very, very pedantic. It used to be 5 parts and it was random. So the last so it included sort of quality improvement project and critical appraisal and da-da-da. So it was a very, very long process. Since August 2021, the Royal College has actually simplified that. And now you basically have the MChem for all trainees sort of giving exams post 2021. And the MChem is split into 3 parts. So it's primary, intermediate, and the OSCE. The primary is the basic sciences, just like any exam, any Royal College exam really. Anatomy, physiology, pharmacology, a little bit of biochemistry, pathology and other things, but largely anatomy. So the exam is largely actually split into anatomy and physiology. Also, it's interesting that I think on the sort of MChem pathway, you could contact the RChem, and if you've ever passed the MRCS part A, they would count that towards your MChem primary, because obviously they're so similar in sort of natures, as it were. So the MChem primary is ideally you need to pass it before finishing ST3 year. So the mandatory requirement by the RChem is you have to pass your MChem primary by your ST3, but by the time you finish ST3. So if you haven't actually cleared it by ST3, then you'll have to take time out of training, or they'd have to prolong your training. You wouldn't be able to sort of go on to ST4. They'd probably give you an intermediate sort of non-training sort of role for a few months or whatever to sort of try and give you time to pass it. So that's where it is. Intermediate can be sort of ST3 4 year, and then the OSCE can be a little bit later on, but you definitely need all 3 sort of parts eventually finished. The pass rate for the MChem primary is unfortunately not very great. I think it's only about 30-odd%. It is a difficult exam. It's held twice a year. normally in June, and then again usually in November or December. So it's not that many times that you can give it within the year. So there's only 2 goals ideally. But if you've prepped for a good 3-4 months, it's crackable. But bear in mind, you need a lot of anatomy knowledge, sort of. It's not just the base anatomy knowledge. So the questions can be quite sort of obscure in the sense that it's generally very applied. So it's very tapered to ED, or patient comes in with a stab wound in the neck. Which nerve, and they present with some sort of sensation loss down the arm. Which nerve do you think is responsible for this? So it can be sort of it makes you think along the lines of what would happen in an ED scenario. So I think that's the primary reason most people find it hard. But like I said, it's about 3-4 months of good prep. There's quite a few prep courses as well online. So it's a matter of just doing the questions repeatedly and learning anatomy reasonably well. There's a fair bit of physiology as well. So it's pretty much, I think, 30% anatomy, 30% physiology, and then the rest really. So physiology also is quite a massive in there. So give it prep time. So what do you actually need to do to reach this stage, or to get into sort of ED training, or to sort of prep yourself? Work in ED, like I said, any sort of work. It could be shadowing, it could be clinical attachment, it could be a day, a week, a taster week, whatever. Work in ED. Show that you've actually been there. You know what you're talking about. You've at least briefly seen it, even if you haven't led a resus call. Pick up procedures. So it's very, very easy. So when I was ST1 in ED, or when I was locuming, I literally saw so many like F2s trying to sort of get hands-on. Normally, the foundation mentality is to stand back and be a scribe, and you're busy sort of doing notes and rewriting prescriptions and doing discharges. In ED, thankfully, you don't have the headache of doing discharges. So the best thing is you go ahead and you actually do the procedures. Tell the registrar, oh, I've seen a nerve block. Can I do it next? It's very, very easy to pick up these things. ED is very procedural. So that's half the reason why I wanted to do emergency medicine. Is it's very hands-on. You're not just a physician. You're actually part surgeon or part anesthetist, because you're doing so much. You do emergency chest drains, we do arterial lines, we do femoral IO accesses and resusces. Lumbar puncture, although it's part of our mandatory ACCS sort of sign off, I'm not very sure how many lumbar punctures we get to do in ED. I've certainly never done one as a locum. I've not seen anyone do it in ED. We normally just give it to the medics and they do it eventually. But you need to be aware of it. If you get a chance, do it. Nerve blocks are very, very easy. So I used to be so when I was in F1, I'd get sort of very, very daunted by these things, because they seemed like heavy procedures that we didn't have exposure to. But nerve blocks are fairly easy. Anyone who comes with a NAF can have a fascial iliac block, and it's fairly simple to do. If you've seen one, then just ask the registrar, and 99% of the time they'll be very happy for you to do it, even if you're junior. So do it and then document it somewhere. Put it in your logbook, put it in your sort of portfolio, but get as many of those things as you can. Fractures, obviously, I've said it so many times there, because fractures are so common. The most sort of common injury sort of mechanism that presents to ED is fractures, Colles fracture, sort of anything, like I said, NOFs, children's fractures. So many kids, especially in the summer months, spring, summer, you'll see so many fractures. Old people, dislocated shoulders. Now, the most common thing, the easiest thing you can pick up is dislocations, fracture reductions, and they're not invasive, they're not complicated. Often a reg can just talk you through them, and they normally requires 2 people anyway to reduce things. So you can just assist them, and it gives you a good idea about what it is. You can discuss the x-rays, you can ask them the types of fractures, you can literally delve into it. So normally in the A&E setting, or what I've come across, is most registrars are really busy, really stressed. They probably don't have time to sort of sit down and ask you, do you want to, they won't come grab you for things, because they're just busy, and it's easier for them to just do it, sort the patient, and bam, that's gone. So don't wait for them to come to you. Go to them and go, oh, I've just noticed you've picked up this fracture. What is it? And then they happily run it with you, because they, like I said, they won't come to grab you for these things. So make sure you are preempting what you can do and how you can learn of things. No one's going to tell you off for asking them about things. So make sure you ask. Although they're stressed and it's a high stress environment and it's very busy, majority of them are really, really nice and very, very sort of pro teaching. So go ahead and do it. And I've just put that in there because this is how a sort of trauma call or a resus call would normally look like in ED. Although we kind of think of, oh, does it look very dramatized and it's not. So every time a resus alert comes or there's a cardiac arrest on the way, this is how an ED would look. So make sure you if this is what entices you, then you've really considered a career in A&E. I know a lot of people, I know there's a lot of negative press around sort of A&Es and ED trainees and how it's a high stress environment and blah, blah, blah. And it is, I won't lie, it is. It's very difficult. You're often working long hours, you're working unsociable hours, your family life is probably struggling, you probably don't have time to meet your friends, you probably won't have many weekends off, but it is really, really exciting. At the end of the day, if you're looking for that sort of, you don't know what you're walking into, that's exactly how I can explain it. And that's why I did it. Each day you get up, you go, and you don't know what you're walking into. You could walk into a really calm department on a nice sunny day and you think, oh, hang on, what's going on? Why are people not ill? Why are people not waiting here? Or you could walk into absolute mayhem where there's literally 5 alerts coming. There's sort of 20 patients waiting in the waiting room for over sort of 4 hours. So you don't know what you'd get. And it's that unpredictability which makes it exciting for me. The other thing is, obviously, I don't enjoy ward rounds. I don't enjoy clinics. I don't enjoy patients lying in a bed for days and days and days, and you're sorting out their medication, and you're sorting out their social care and your package. ED is quick. So if you're someone who likes fast turnovers, fast things, then it's something you should definitely look into. So they come in, they go, bam, and that's it. And you're done. Yes, you do have the large majority of patients who obviously don't need to be there. There's the back pains and the chronic leg pains, and they think they can't see their GP, so they've turned up to ED. It does happen, but I think the excitement of when you have a scenario like this sort of beats the sort of odd times when you pick up a patient who doesn't really need to be there, or the alcoholic, or the overdose who's come for the sort of 10th time in the gone month. So if this is your calling, then definitely consider a career in ED. But like with anything, make sure you've been to an ED, make sure you've seen it, something about it that is sort of hit a nerve with you, and make sure you elaborate on it and you're able to explain it. Like I said, not all of them require sort of a substantial job in ED. Not all consultants or all sort of assessors would require a job in ED. But make sure you've shown some sort of interest in it. So yes, that's where we're at. And any questions, if you have any questions, then feel free to ask.
I actually have one question.
Go on.
When is the best time to do exams for A&E? Because I know core surgical, they recommend to do it as an F1 already. What about for A&E?
So you can do it as an F1. You're eligible to do it as an F1, obviously, post MBBS. You can do most of the primary exams for most Royal Colleges you can do as an F1. No one would stop you from doing them. So if you're attempting the MRCS, and if you want to attempt the MChem, you could easily do so, because they're very similar. Like I said, the revision patterns would be similar. So if you're revising for one, you can easily give the MChem as well. So yes, you can start as an F1 if you want, but ideally, I personally would advise people to wait until, if they've got an F2 job as an ED, F2, then I would probably wait until you do the job, solely because you'd understand some of the questions a little bit better. Especially questions which are sort of directed towards ED training. So most of the primary MChem primary questions would say, oh, you're a junior doctor seeing a gunshot wound on a blah, blah, blah. What would you do? So it's things like that. So I would think it's easier if you've had some sort of job in ED, but you can give it as an F1. There's nothing to stop you from. So, and the question banks will prep you for it anyway. So you can easily give it as an F1. And like I said, you need to finish the MChem primary by the time you finish your ST 3 years. So the earlier you start, the better, because some people actually have given their MChem before entering training, before even starting ACCS training. I know of at least, I think half of the people who started with me as ST1s had already done their MChem primary the year gone. So most people do the MChem primary, and then within the sort of ST1 2 years, they'll give the MChem intermediate, and then the OSCE can be sort of a little bit later on.
All right, cool. Anyone else have any questions?